All right, sorry for the little delay in the thing. This week we're going to talk about reproductive technologies, and we are actually in the week 4 of the semester. And so this week you'll have lecture and you will have a discussion in your discussion groups. So what we're going to talk about in our objectives is we want to understand some terms such as infertility and subfertility. We're going to talk about some assisted reproductive technologies. We're going to learn a little bit about in vitro fertilization. We're going to talk a little bit about pre-implantation genetic screening and maybe what we should do when we have extra embryos. So first off, what is infertility? As you can see, it's that the inability to conceive after at least 1 year of frequent trying and the use of no contraceptives. So subfertility means that perhaps conception is possible. However, it takes longer than usual to be able to have implantation and therefore birth. So there are some issues with women. They tend to be decreased fertility. Perhaps they have a chromosomal abnormality. There's fetal death, premature birth, and pregnancy-related health issues. That's with women of advanced age. They may take longer to be able to conceive. They may need some assistance in being able to do that because of these particular issues that we see in their age. For men, generally as they age, it is the sperm begins to slow down or is less mobile. There can be male infertility. More often than not, this is easier to diagnose. There is about a 25% chance that most men are infertile or have some infertility issue going on. There's oligospermia, which means they have a low sperm count, and this can be related to hormonal imbalances. The immune system may be producing some IgA antibodies. This also could be related to injury or illness. Men can have varicose veins within the scrotum, which then can cause the sperm to be less mobile and have a lower sperm count. And sometimes there are genetic causes. There is a deletion that occurs on the Y chromosome. And then there are some mutations that occur within specific gene segments or within their genetic makeup. This is a picture of what a immobile sperm might look like. Okay, so with women infertility, it can happen within any area of the female reproductive system. This is just a schematic of the female reproductive system, so you can get a little visualization of what we're talking about. We know that the ovaries produce the eggs and they release them. The fallopian tubes are the tubes that carry the eggs to the uterus, and that is generally where fertilization will take place. The uterus, or the endometrium lining of the uterus, is where implantation takes place, and the cervix is the opening that connects the uterus to the vagina. This is just kind of some hormonal issues. We can see that if we have an issue in our pituitary gland, that can affect our fertility. We could maybe have an extra or missing chromosome that relates to our ovaries, so that may alter our production of oocytes, or they may be misformed. We can have blockage or scarring within the fallopian tubes. Your uterus can be an abnormal shape. We know that the cervix can have some issues with it, such as cancer, or we can have disease. We know that within the vagina, sometimes there are women who actually have vaginal secretions that actually kill sperm. And endometriosis can make it difficult for implantation as well as fibroids. Women with irregular menstrual cycles have a difficulty with conception and pregnancy. This is because they don't ovulate on a regular predictive basis. A lot of these women can find some benefit in using an ovulatory predictor kit. They could also monitor their temperatures and if they have lab tests that detect some hormonal imbalances, having those corrected with medication. There could be uterine tube blockage. We could have excessive growth within the uterus, such as fibroids, excessive vaginal or cervix secretions, which can be thick, or they can kill the sperm, they can slow their motility down, or you can have some genetic or some chromosomal changes. So with female infertility, like we said, there is a hormonal imbalance which can cause the irregular ovulation. You could have a tumor in the ovary or within your pituitary gland. Hypothyroidism can be a cause of female infertility. Women who use steroid-based drugs can have changes in their fertility, which is why if women are wanting to get pregnant, a different drug choice, if possible, is considered. We know that fertility drugs, the purpose of them is to stimulate ovulation, but with that there is the possibility of multiple release of more than one egg. So sometimes women's ovaries are inactive or absent, either from fetal development or because of surgery or cancer. So here are some signs if you have a reduced ovarian reserve. Your ovary has too few follicles to develop. You tend to have elevated levels of follicle stimulating hormone. You could also have a blocked fallopian tube. This can either result in the egg not being fertile at all, or that the sperm is small enough to get through the blockage. However, the egg cannot pass through, so implantation takes place in the fallopian tube. You can have excessive growth in the lining of your uterus, which this creates what we call an inhospitable or an unfriendly environment for the embryo, so it won't implant. Or if it does, it doesn't implant for very long. Fibroids, endometriosis. You can have secretions that create a hostile environment to the sperm. It either slows them down or it kills them. And can be the result of your oocyte fails to release any sperm attracting chemicals. There are chemicals that are released by the oocyte that attract the sperm to the egg. There are infertility tests, and so usually men are checked first because theirs is the easiest to fix if there is a problem. And it's less costly. Sperm is checked for number, motility, and their shape. And then a gynecologist is used to check the female, because then we want to look at the reproductive organs to see if they're all present and what their functional status is. And also in this process, it's a good idea to look at psychological factors such as stress, worry, overwork, those types of things that could be impeding fertility. Then we have some assisted reproductive technologies, or ARTs. People use these if they have fertility problems, and this is a way for them to be able to conceive. Some examples include intrauterine insemination, surrogate motherhood, in vitro fertilization, gamete intrafallopian tube transfer, zygote intrafallopian tube transfer, banking of your eggs, either to use at a later date or to donate to someone else. And during this process, you can get some pre-implantation genetic diagnosis done. And you can have sequential polar body analysis. So a donated uterus. So we can do this by a surrogate, in which we use the male sperm and a surrogate egg and the surrogate uterus. So we can have a gestational surrogate, and this uses both biological partners' egg and sperm. And then there's a transfer of the fetus to a surrogate uterus until birth. Intrauterine insemination, donated sperm is placed in the woman's cervix or directly into the uterus. This can be their partner's sperm, or this can be such a sperm where you don't know the exact name of the partner. You've gone to a sperm bank and you've chosen one. Success rate is about 5 to 15%. When you look at sperm catalogs, they often list personal characteristics. They may also list a health history, which they're asking for, which is important when you look at things that run in families. You can have in vitro fertilization. The sperm fertilizes the oocyte outside of the uterus or the fallopian tube. The embryos are then transferred to the uterus, either that of the woman who donated the eggs or to a surrogate uterus, and this is where implantation takes place. Woman can undergo IVF if her ovaries and uterus work, but her uterine tubes perhaps are blocked. Oocytes from an ovary are removed through laparoscopic surgery and then transferred to the culture dish. This is kind of a little bit of an example. They take the oocytes, they put them in the dish, and then they wait for them to grow and multiply, and then they'll put them back into the uterus for implantation. There's about a 25% chance of live birth. And these embryos that are not implanted but have some growth, they can be frozen to be used, cryo freezing, to be used at another time. So there's intracytoplastic sperm injection. This is that the sperm that cannot enter the oocyte is micro-injected into the oocyte that is inside the woman's natural anatomy. It is more effective often than just IVF alone. It allows for conception, especially in low sperm counts or many abnormal sperm, because they will get the sperm sample and they'll remove the abnormal sperm, or they'll be able to take a few samples and create a large amount of mobile sperm. This can happen when there is a male who perhaps has had a spinal cord injury and has very good sperm count or low sperm count, but because of their spinal cord injury, ejaculation is not possible. There's gamete intrafallopian tube transfer. This is a method which large oocytes from the woman and the sperm from the partner are placed together in the fallopian tube. So they put both in the fallopian tube. Fertilization occurs within the woman's body, and it allows conception in the case where there's fallopian tube blockage. So they would do the fertilization at the part past the blockage closest to the uterus, or within so that implantation would take place. About 22% chance of success. You can have zygote intrafallopian tube transfer. This is when the IVF ovum is introduced to the uterine tube and allowed to move to the uterus itself for implantation. So the implantation, it's actually allowed to do its normal course where it comes down the fallopian tube and then makes its way to the uterus for implantation. It's also about 22% chance of success. Both GIFT and ZIFT are done much less frequently than IVF. This may not work if the woman has scarred uterine tubes or fallopian tubes. Oocyte banking and donation. Oocytes, like sperm, can be stored frozen. Women can store their own oocytes to have children at a later date or prior to undergoing chemotherapy. Oocytes are frozen in liquid nitrogen. Difficulties exist as the oocytes pass in the meiosis II stage until fertilization occurs. So they kind of pause its own cellular growth or any type of cellular division until they're ready to thaw them, and then you would have to use IVF to unite the egg with some sperm, and then that fertilized egg would be transferred back. About 3% successful. And some more about banking. New techniques are being taken every day where you can freeze strips of the ovarian tissue. Women can obtain oocyte from donors. Say you are a woman who maybe went through chemotherapy, didn't think about freezing your eggs. There are women who have donated their eggs to an oocyte bank similar to a sperm bank, and you can use another woman's eggs. Embryo adoption is a variation of oocyte donation. So it could be someone who did attempted IVF, was very successful, but had very healthy embryo that were frozen and they weren't going to use them anymore. Some couples do allow adoption of their embryo to a woman who would otherwise not be able to. A woman with malfunctioning ovaries and a healthy uterus can usually carry the embryo. Her partner's sperm is used in intrauterine insemination of the woman who produces healthy oocytes. Their cytoplasmic donation. Older women can have their oocytes injected into cytoplasm from an oocyte of a younger woman to help rejuvenate the oocyte cells. I'm not really sure I understand this, but it's a new and way of looking at being able to have a child as an older woman. Oocyte donation technology is behind that of a sperm bank. It's new, so it's running through its complications, through its ethical dilemmas, through how to work through the process. Oocytes are harder to obtain than sperm because they do have to be removed laparoscopically. And often these women who are donating will take infertility drugs so that when their oocytes are harvested or removed, they are removing more than one. You can now get pre-genetic diagnosis before you implant. So this is helping them look for genetic or chromosomal abnormalities before they implant the fertilized embryo in the woman. So it's tested to see genetically to see if there are any complications. One cell or blastomere of an 8-celled embryo can be removed for testing without any complication to the embryo itself. And those that are left continue to develop normally. This prevents the implantation of a genetically altered embryo and helps the parents be able to have a healthy as you can child and maybe carry their child to term. So accuracy of detecting mutations or abnormal chromosomes is about 97% in terms of being able to see what is there. Errors can happen as there is cell development. It can be used to screen early embryos for normal chromosome numbers before you implant them to make sure we don't have a trisomy or we're only a single chromosome where there should be 2, or that those chromosomes are normal looking. It helps increase the success and chances of a successful live birth. The technology is often used sometimes for gender selection, but people consider that to be a misuse of the technology. The first child who had PG9 was done in 1989, and it was used to select a female birth that had not inherited an X-linked condition from their mothers. So this is just kind of a picture of how things kind of look. Oocyte banking, we talked about that a little bit. Remember, the procedure is invasive for a woman. So what do we do with our extra embryos? So with this type of technology, there are often extra embryos. Many IVF embryos sit in freezers. It is up to the couple to decide if they want to donate their embryos to another couple or perhaps donate them to be researched. It can help researchers study some early aspects of human development that perhaps that there would be no other way to investigate those. It is very controversial to fertilize, to research on these discarded ovums or embryos that aren't used, but they are developing regulation to fund some of this research, and they are looking at the ethical components of this. So this is just kind of a schematic. So these people shipped 14 embryos to Virginia. Okay. With approval, the Lindermans sent 12 ovaries to California for an anonymous couple to use. One had twin daughters, one had twin sons. So these people donated, okay, and this is a very unusual tree, so they went to there, and then these people chose, and then they sent them on to be used again. So as you can see, 3 families were benefited from one couple's fertilized embryos. So this is kind of, it's hard to read, and I apologize for that, like what you would look at if you were looking at a fertility specialist, some things you would want to look at. So you'd want to look at their history, both any psychological or financial issues. What is their health history? Some screening tests. You want some diagnostic tests. You can see that the men's diagnostic tests are far less than the woman's. And so what happens if we get abnormal test results, depending on who it is? That's what it is. So this is another way to explain IVF. And that's the end of today's lecture.